Nearly a minute till showtime. Okay, so it's 10:40, so we'll start. So welcome back, everyone, to our final and third plenary session for the 54th Annual Gatlinburg Conference. My name is Rodney Samako, and I have the honor and great pleasure to introduce the next speaker, an emerging leader, Dr. Jessica Duis. Dr. Jessica Duis is a pediatric geneticist and special care physician at Children's Hospital Colorado and the University of Colorado Anschutz Medical Campus. She did her medical training at Johns Hopkins, including a research fellowship in epigenetics in the Department of Psychiatry and Genetics at Hopkins, then went on to Vanderbilt to found the Comprehensive Prader-Willi and Angelman Center in 2016. In 2020, she moved to Colorado and started Centers of Excellence to serve individuals with chromosome 15q disorders and expanded her work on Angelman and Prader-Willi-like disorders. Her research focus is on standard of care clinical practice and building the foundation for successful therapeutic trials, and she sees patients with rare disorders with a focus on precision medicine. So today, I'm very excited to hear her work on outcome measures that can be implemented across many different NEDs, and I think very appropriate for the conference theme with respect to clinical interventions. She also has grant funding and from several foundations as well as industry partners to continue developing remote monitoring devices in natural environments and understand how they can be clinically meaningful. I think this will resonate with many of us who are working from home in this past year, and also has been funded to create an emergency line for AS, that's Angelman syndrome, to ensure that all individuals have access to standard practices and up-to-date care. So with that, Jessica, the floor is yours.
Thank you so much, Rodney, for that kind introduction. I'm going to go ahead and share my screen and get my slides going here. So as Dr. Samako said, I'm very excited to be here to talk about the road to personalized therapies, really from A to Z, and I'll be utilizing some of the lessons that I've learned along the way from looking at chromosome 15 disorders, in particular Prader-Willi syndrome, Angelman syndrome, and duplication 15q. I have a few disclosures for consulting. So let's start with the roadmap to success and why did Angelman syndrome become so uniquely positioned to be one of the first neurodevelopmental disabilities to have precision medicine? So if we start from the beginning, there are certain things that there has to be in place to move forward with development of therapeutics and also successful clinical trials. One of those would be basic science understanding, and we'll talk through how that occurred for Angelman syndrome. You need to understand the key aspects of the disease, and having care standards is very important, which I hope I will impart to you today. Natural history is obviously very important. And then you want to have the right outcome measures that really capture the most consistent concerns from patients and caretakers. Of course, you always want to be aware of where your shortfalls may be, and I hope I'll highlight some of those today. So let's talk about the journey to therapeutics. And really, this was key for Angelman syndrome to get to the point where it is today. It had a huge part from patient advocacy groups to get us to where we are today. So let's start with what we had to do first. So the first clinical description from Harry Angelman of Angelman syndrome was in 1965, where he described 3 cases of individuals with Angelman syndrome and called them puppet children. The specific features that he saw were inappropriate laughter, jerky mannerisms, and flapping of their hands. From there, it took quite some time to molecularly understand the underpinnings of Angelman syndrome. So if we look at chromosome 15, and this is the chromosome 15q11.2 to q13 region, this is a very unique region of our genome. This region is what we call imprinted, meaning that certain parts of this chromosome are only expressed from the paternal copy, and other parts are only expressed from the maternal copy. So for Prader-Willi syndrome, you'll see in blue the genes that are only expressed from the paternal copy, and then the yellow are the genes expressed from the maternal copy. What we came to understand about Angelman syndrome originally in 1987 is that individuals who have a missing part of chromosome 15 from their maternal copy have Angelman syndrome. It wasn't until 1997 that we came to understand that the specific gene of interest in this region that is maternally expressed is the gene UBE3A. And there are several mechanisms by which you can have absent expression of the gene UBE3A. You can have a deletion of this region of the chromosome. You can inherit 2 copies of your paternal chromosome 15. You can have a defect in how the imprinting occurs at the imprinting control center. And you can also have misspellings or mutations in the gene UBE3A itself. I mentioned Prader-Willi syndrome here primarily because there is a dichotomy between these 2 syndromes in the sense that we have come a very long way in terms of precision medicine and personalized therapeutics for Angelman syndrome, but we remain primarily focusing on symptomatic management for Prader-Willi syndrome. And the reason for that is that while we've been able to hone in on UBE3A for Angelman syndrome, we haven't really honed in on a specific gene in this region for Prader-Willi syndrome. There are some hypotheses that specifically the small nucleolar non-coding genes here play a role, in particular SNORD116, but that has not been proven. So one of the things that was most important was to understand how imprinting occurs for Angelman syndrome. And we know that this imprinting occurs only in the central nervous system. So in non-neuronal cells, you have biallelic expression of UBE3A from the maternal and the paternal copy. However, in the neuronal cells or the central nervous system, what we see is that there is silencing of the paternal copy through a long non-coding RNA called the UBE3A antisense transcript. And so, for example, in a deletion, what you can see is that you have a naturally silenced paternal copy and no region for expression from the maternal copy. So the next step is really to have translational models to study preclinically potential therapeutics and mechanisms for therapeutics. And so this was really important for Angelman syndrome. Let me go back, hold on. Sorry. So a mouse model was discovered by Dr. Zhang for Angelman syndrome with absent expression of the maternal copy of chromosome of the UBE3A gene on chromosome 15. And that resembled the human phenotype in several ways, in particular motor dysfunction, inducible seizures, and context-dependent learning deficits. And that was very important because it gave a model through which we could study things preclinically and ensure that we were seeing differences and potential rescue, which I'll talk about going forward in just a second. In addition, Dr. Mark Lalande discovered that iPSCs could be used to study Angelman because in the process of differentiation of these cells, the paternal imprint was maintained, which was very important to see. And then most recently in 2020, there was a rat model that was described for Angelman syndrome that showed deficits in motor coordination as well as learning and memory, offering another model to study Angelman syndrome. And then the last step is rescue. And so it was very exciting when in 2011, Dr. Weber's group published this paper showing that with AAV-mediated gene therapy, they were able to show that in the hippocampal region, you can have re-expression of UBE3A similar to the wild type. And similarly, you can see here, if you look at expression of protein E6AP, which is the protein expressed from the gene UBE3A, that you have re-expression with introduction of that AAV-mediated gene therapy to similar to wild type. Similarly, the Ben Philpott's group published around the same time that the use of topoisomerase inhibitors, such as topotecan or irinotecan, can reactivate the paternal copy of chromosome 15 acting in cis. So this is targeting the UBE3A antisense transcript. So where are we with respect to Angelman syndrome? There are a lot of very exciting trials, and actually there are 21 companies that are interested in Angelman syndrome and working on personalized therapeutics. However, one of the things that we caution is that whether we are really ready for all these trials. And so one of the most disappointing pieces of news from the end of last year is that one of our first clinical trials that was a small molecule looking at targeting tonic inhibition, which is a known mechanism of Angelman syndrome's clinical features, they did not see a change and did not meet their primary endpoint in their pivotal trial. And this was very disappointing. Their primary outcome in this trial was clinical global impression scale, which is an emerging outcome measure many neurodevelopmental disorders are using. And so one of the thoughts about this is whether this could happen with actual precision medicine or targeted therapeutics that really target the known mechanism of Angelman syndrome. And if we look to other disorders, most recently Duchenne muscular dystrophy, gene therapy trials have failed. And the question is it due to lack of efficacy, or is it a problem with how we're measuring success in these clinical trials? And so I'm going to take you through some lessons I've learned from an investigator-driven clinical trial that I conducted on an exogenous ketone. So thinking about starting this trial, there was a lot of really exciting evidence that this would be a successful treatment for Angelman syndrome. So one thing we do in regular general treatment is that we think about utilizing the low glycemic index therapy, which is a restricted carbohydrate diet that has been shown to be successful in Angelman syndrome. It's less restrictive than the ketogenic diet, although success for the ketogenic diet has been described previously in Angelman syndrome. And so if you look at these EEGs, you can see that there's an abnormal background. Particularly, we look for something called a delta wave, which you can see there's some delta waves here, which is evidence of the abnormal background and ultimately here you can see there's significant epileptiform discharges or seizures here. After the ketogenic diet, you're left with no significant epileptiform discharges, although you still see the background that's common in Angelman syndrome. And we also had the preclinical data. So Dr. Ed Weber's group had shown that use of ketone ester supplementation impacts seizure activity and improves behavior and synaptic plasticity in individuals with Angelman syndrome. So we were very excited getting this trial started. So this was our trial design. So it was the first clinical trial to ever be conducted in individuals from age 4 to 11 in Angelman syndrome. And we knew with many therapeutic trials coming, this was going to be the target age range. And we were very excited to be able to look at this compound, both focusing on the safety and tolerability of the formulation, but also thinking about how we might pilot some outcome measures that could be useful to companies going forward. So individuals in this trial had a baseline period of monitoring, followed by randomization to either the formulation or to placebo, a washout period, and then a crossover to the other compound, either placebo or formulation, followed by another washout period. So everybody in the trial did receive the formulation. And we were very excited to do everything we possibly could to get as much information about outcome measures, both because to assess the safety and tolerability of this compound in Angelman syndrome is challenging because they are nonverbal and unable to communicate with us if they're feeling different. And so one of the reasons we also collected so many outcome measures is we wanted to make sure if we were seeing a change that we were able to detect it well, especially something that could indicate that they were having some risks from taking the formulation. So at each visit, we did blood sampling, EEG recording, ERP recording, and a mobility evaluation. And the trial was a total of 16 weeks long. The other thing we really prioritized was home monitoring. So we really wanted to try to collect outcome measures in the natural environment. And so I'll take you through some of these and some of our thought processes with these. Taking a step back, this was our outcome measure wish list. So we wanted to have an outcome measure that was seen to change preclinically in the mouse paper that Dr. Weber had published. We wanted to make sure that this was clinically relevant, and around the same time we were starting the trial, a disease concept model had come out on Angelman syndrome, and so we really wanted to focus on some of the features of Angelman syndrome that caretakers and clinicians had noted to be particularly bothersome. We also wanted to be very objective, so we were trying to stay as much as we could away from subjective outcome measures. And we really wanted to think about how we could observe individuals in their natural environment and get information through their day-to-day life as opposed to having them come in artificial situations. And so we looked at a biomarker. We thought ideally a good clinical trial would have a biomarker where we could detect change. And preclinically, we had seen that beta hydroxybutyrate, which is a ketone produced in the body on ketogenic diet or fasting, had increased in the animals that were on the particular ketone ester studied. And so this was very clinically relevant, as oftentimes, particularly in the more restrictive ketogenic diets, we will measure levels of ketones with urine studies um, at or with lab work to ensure that they're in ketosis. And so we had a nice biomarker available, and we asked families to collect urine and blood ketones at home. And I'm not going to show the data, but this did not show a change on the supplement, which may be consistent with what we see often with the low glycemic index therapy, in the sense that most individuals on that diet will not consistently be in ketosis. However, one of the things we really learned is that use of this biomarker doesn't really say anything about the success of the clinical trial itself. It was a marker of compliance in the sense that individuals who had elevated ketones that didn't have them during the baseline period, we felt more comfortable they were likely utilizing the formulation at home. This biomarker was really dependent on environment and background diet. And ideally, we would have seen that there was a correlation to some of our outcome measures of our biomarker. The next thing we looked at is EEG, and there's been a lot of work on quantitative EEG in Angelman syndrome. So from a preclinical perspective, we had seen that there was improvement in seizure activity in the preclinical data. What we know and what's clinically relevant for Angelman syndrome is that there is that increased delta power that I had mentioned previously. So individuals with Angelman have an increased delta power that is statistically significant compared to controls. And this is actually also observed in the translational models or animal models. So is potentially a good outcome measure. And it's very objective. We hook them up to the EEG, and their brain activity is their brain activity. And so we were very excited about use of this as an outcome measure. And I just want to highlight what we saw in our study at the baseline compared to controls is that delta power changes over time, and it decreases over time in Angelman, although it remains higher than the control population. So I mentioned this, and I'm going to come back to it because it is really helpful to know that natural history of this and how it changes over time, or what the slope would be of this change in delta power for Angelman syndrome over time if you're going to consider utilizing this as an outcome measure. So in our study, we were very excited to see that compared to the baseline in the placebo group, there was a suggestion that the delta power was decreasing in these individuals over a short period of 16 weeks. So the challenge with this is that at the end of the day, when we tried to look at this quantitative EEG finding and this suggestion that it decreased over time, we weren't sure what it meant. And so it wasn't clearly correlated to other outcome measures, at least in our small study. And that meant we didn't really know if it made a difference long-term in Angelman syndrome to change the delta power. And interestingly enough, we had an individual in this study who had a large deletion causing Angelman syndrome, so molecularly confirmed Angelman syndrome. And on his first EEG, he had a normal EEG. He didn't have any change in his delta power from the baseline of what you'd expect from a typically developing individual. And so he was on a new medication that hasn't typically been used in Angelman syndrome, and it looked like maybe that was impacting his delta power, because when he was off of it, when we looked back at his old EEGs and his EEGs going forward, the delta power was there. So we really also must understand the impact of other environmental factors on delta power. Similarly, we must understand how delta power changes over time to really use it successfully as an outcome measure. We also looked at sleep. So from a preclinical model, it looked like there's a difference in the GABA glutamate ratio, which is known in Angelman syndrome to be decreased. And so we knew this was clinically relevant since many of the individuals that we follow with Angelman have significant sleep disturbances. And we know that activation of GABA A receptors favors sleep. And so this is part of the mechanism of several other drugs that are coming online for Angelman syndrome, but also for the OV101 drug that failed in phase 3 clinical trials. So we thought about how would we best measure sleep, and the gold standard to measure sleep would be something called polysomnography, where we have the children come in and stay overnight and measure their sleep. However, this is not something we're very successful with Angelman syndrome, in particular because of the anxiety-producing nature of that environment and it being a new environment. We often don't get good sleep information from overnight polysomnography. And so we decided to use a novel device called the Early Sense device, which actually gets placed underneath the mattress. So the child does not have to be attached to anything to utilize this device. And this device had actually been validated in typical individuals in comparison to that gold standard polysomnography. So we're very excited about using this device in this study. And this device showed some very exciting data in the baseline period and throughout the study, although it didn't change in the study between the placebo, baseline, and treatment groups. So what we saw, this is just a small part of our data, but what we saw in these few patients that we've analyzed so far is that their number of nighttime awakenings was very high. And this is consistent with what we know about Angelman syndrome. So awakenings range from every 1.2 to 3.2 hours of sleep, the individual with Angelman was awake. And similarly, when we compared what we learned from the individuals in this study to historic data on polysomnography and Angelman syndrome, we saw that we had similar results. comparatively. So you can see that their time awake, their time asleep, and their sleep latency, so the time it took them to fall asleep, was consistent between these studies, which was very exciting because it suggests that we may be able to successfully utilize some of these remote monitoring devices to get information about sleep. And I will tell you, one of the individuals in the study actually was diagnosed with sleep apnea based on the results from the sleep device, because we were connected at all times to those individuals who were utilizing the sleep device, and we kept getting alerts that that individual may be having some changes in his heart rate and breathing rate that were concerning, and we were able to send him to be evaluated, and he did have sleep apnea. So we learned a lot from this device. I think most of it was very exciting because we know that polysomnography has been very challenging for individuals with Angelman syndrome. We haven't quite figured out how many hours of data we would need to say that this is valid, but it is a great opportunity to monitor in the natural environment, and it required that the individual in the study not wear it or their ankles, which was very helpful in ensuring that this would be a potential successful outcome measure. The one thing that was challenging is that sometimes the signal was difficult. So if we had a parent in bed, we had to have the families make sure they indicate that to us. And oftentimes we noticed that with this remote monitoring, it was taking the average between the two individuals in bed. The other thing we looked at is auditory event-related potentials. So we knew that the ketone ester study had shown that memory was impacted with novel object recognition. And we also know that in terms of measurement of cognition in Angelman syndrome, our best measures do have some challenges in terms of individuals with Angelman syndrome often reaching a ceiling around 24 months of age. And so we wanted to look at cognition through this objective measure, which is similar to EEG in the sense that they put many different electrodes on the head or a cap on the head and look at output from the brain during an activity. And we utilized a repeated non-word compared to novel distractors task or an auditory task. What we saw with this was very interesting. We saw that individuals with Angelman on the active formulation had this emergence of a frontal response that was statistically significant and occurred in both the 250 to 500 and 500 to 800 millisecond windows. And so that was very exciting. However, we have no idea what that meant. It didn't correlate clearly to any of our other outcome measures, including the Vineland. And ideally, when you're utilizing event-related potential, because there's still a lot unknown about what it means, it's helpful to have it correlated to outcome measures utilized in the trial. And then again, another important point is that we do know that individuals with Angelman syndrome do learn over time at their own pace. And so the natural history of how this changes over time is not really known. And that's important because just like delta power, if there's a change, an upward trajectory or a sign of cognitive response, we don't know if that's similar to what we would expect for a baseline for an individual with Angelman, or if it's the rate of change is higher in the clinical trial. One of the other things that I only mentioned because we saw a statistically significant change in it on the ketogenic formula is stool consistency. And stool burden is a big one for individuals with Angelman. They have significant constipation. And we did see that in our 13 individuals who completed the trial, there was a statistically significant improvement in stool consistency in the treatment group. So we learned a lot from this trial, and some of this we're still struggling with. A lot of the feedback that we've gotten from this trial is that we potentially should have selected individuals who have more significant epilepsy. And this was very challenging. I think there was a large burden with the number of things we were collecting and with travel. And so we ended up taking all comers to the study, which naturally selected individuals with Angelman with less of a seizure burden. And we may have been able to be more successful if we had targeted individuals with significant epilepsy. You know, we always want to make sure something's safe first and that we're weighing the risks and the benefits anytime we introduce a new therapy. And this was something that we thought about a lot because we weren't sure we were going to be able to successfully measure if someone was having side effects, given the inability to articulate that to us. We also really were interested in what were the relevant outcome measures, and we're still learning this. There isn't anything absolutely clear that has come out of this where we can say that this is the right outcome measure to look at in Angelman syndrome. And now that we're on the other side of the clinical trial, and we did see that there were some benefits, we're at this point where this is a nutritional formulation. And so the company that designed this for us, called True Macro, has brought this to the market. And so this formulation is available. We definitely think it's safe. However, what's our threshold to recommend the use of this? And similarly, what post-market research should we be doing? Should we be measuring some outcome measures to determine in a larger size of population if we do see some side effects that we didn't pick up in our trial? And, you know, of course, COVID-19 did impact our clinical trial. We had plans to open additional sites and do some additional recruitment for the study to increase our N, and that just wasn't able to happen, both from a financial standpoint at this point and also from the standpoint of travel. But this trial did allow us to do some additional collection of outcome measures in the natural environment, in part because of the COVID-19 pandemic. And we utilized a device that we had been looking at and studying called the Actimio device, which can be worn on both ankles of the individual and create a 3D rendering of both. In the case of Angelman children, we put it on their ankles, so it was just a 3D rendering of their lower limbs. And this allows data to be sent in real time to look at compliance during the study as well. And this was very, very well tolerated in individuals with Angelman. We were worried that they would pull it off, and we didn't really see that. So I'm going to show a rendering of what this captures. So every 0.2 seconds or 2 milliseconds, you get some data back from this device that starts at the beginning of the gait cycle, which is the red line, or the beginning of a step, and then you can see that it captures the movement of the individual in each step. And from this, you can get the stride length, stride duration, and stride speed. So these are really temporal measures that you can get from this device. So what do we see from this? And this is a device that has been used in other studies, in particular with spinal muscular atrophy and Duchenne muscular dystrophy. And what we saw, particularly when individuals with Angelman syndrome need to increase their speed to the 95th percentile for their overall speed, so their highest speeds, they really were unable to do this. So what we saw is that individuals with Angelman are unable to adapt their gait to their environment. And they have a very stereotyped walk where they always walk the same. And this initiated a theory that individuals with Angelman really can't get into a running stance and can't run. So again, this brought up, how is this relevant? And how does this impact individuals with Angelman syndrome clinically, and brings up the question of whether our outcome measures are really ready for phase 3, in particular clinical trials. And so I took a step back thinking about what I know from Angelman syndrome. And one of the things that has emerged in our clinical practice that really had not been captured in prior and ongoing natural history studies was the change in gait that we were seeing. So, this is a known component of Angelman syndrome and has been listed as one of the most consistent features of Angelman syndrome, in particular noted as a movement imbalance disorder. But if you look at this data from a review that was published, movement and balance disorders are more consistent features of Angelman syndrome than things that people generally associate with Angelman syndrome, like seizures and small head. And we also added to this a flex knee gait pattern, which we were seeing in clinic. So over time, what we see is that many individuals, as many as 80%, have a change in their gait pattern over time where they're flexing their knees. And we've actually had a few people, especially with some subtypes of Angelman syndrome that are less likely to have seizures, such as uniparental disomy, have this feature of Angelman syndrome that has actually brought us to a diagnosis of Angelman syndrome as late as 12 years old. So we looked at this, and what we were seeing clinically was that this was changing over time, starting around the age of 10, when kids were pre-pubertal, and we were noticing that this change was getting worse over time once we started to see that pattern of kids walking closer to the floor with a deflection in their knee. We started to see that it got worse over time. And so what we saw, particularly with walk ratio, which is calculated by dividing the step length by the cadence, which is a very nice marker to look at how quickly someone's walking, what we saw is an emergence of this difference compared to typically developing controls in this age range of 8 to 11. And I mention the spasticity specifically because our understanding of spasticity was that this was playing a role. And much of the literature on Angelman syndrome has shown that individuals with Angelman develop spasticity over time. But when we looked at this from an objective standpoint with a modified Ashworth scale, we saw that on this scale, with normal being 0 and 4 being rigid, that individuals with Angelman syndrome, even when they were in this flex knee gait pattern, which they all were in this particular study, showed no change in their level of spasticity or very minimal change, which led us to wonder what is causing this change. Similarly, what was very distressing from a clinical standpoint, and we were able to use our Actimyo device to understand, is that individuals with Angelman, particularly once they make this transition to this flex knee gait pattern, actually travel shorter distances and develop a decreased quality of life and more sedentary lifestyle. And so we went back to the gait lab against our original thought of making sure we always do things in the natural environment. But we wanted to go back to the gold standard to study this and understand what was causing it. And what we found is that individuals with Angelman syndrome on 3D kinematics develop that flexion in their knee, which is what we were seeing clinically, but here we can quantitatively measure that change. And that there is a little bit of a difference between the right and the left, meaning that there's some asymmetry in these individuals. Similarly, when we looked at some of the data from the 3D kinematics that I'm not showing here, what we saw is that they also have increased anterior pelvic tilt and flexion at the hips. But what we didn't see was what's called dorsiflexion or flexion at the ankles that is often associated with what's known as a crouch gait. So in the medical literature, there had been one case series or kind of natural history study of a group of patients that was seen in the Netherlands, and they classified this as a crouch gait. But what we saw from our quantitative measures is that it may not be accurate to call this a crouch gait. And we wanted to understand what is really behind this. So we looked at electromyography to look at if we could see just utilizing surface electrodes to see if we could actually see a change in what was going on at the muscle level. And so if you look at the quadricep muscle, you can see that there's this prolonged activation in the stance phase, which is consistent with that decreased power that we're able to see from the hip because that individual has their knee flexed, and that there is a prolonged activation of the muscle to actually keep that individual upright. And if this didn't occur, then and the muscle was not prolonged in activation, the individual would fall. And similarly, our next steps and our thoughts are whether this particular measure of motor development could predict other outcomes. And in particular, when we look at the literature, and this is from a group that looked at autism spectrum disorders, what we can see is that oftentimes gross motor ability can predict communication skills and other cognitive abilities. And we definitely think that this is relevant to Angelman syndrome because individuals with Angelman syndrome, as part of their expressive language difficulty, likely have apraxia, where they have difficulty with motor planning. A lot of times kids with Angelman are very communicative, but they don't use typical strategies that you or I would use, like talking. But many of them become very proficient with devices. And so we know that their cognitive ability is in there. We just don't have a good way of measuring it at this time. And similarly, one of the things that was great about this work is that we were able to collaborate with Dr. Silverman at UC Davis and look at common outcome measures that could be measured across species and translationally, which makes this even more exciting because if we understand how this can be used in a preclinical model, we can create clear outcome measures for clinical trials going forward. And so we really have learned a lot about what we think a primary outcome measure should look like. First and foremost, it absolutely should be clinically relevant. It should have ideally a biomarker correlate that both validates the outcome measure and the biomarker as well. It should be translational. It should be objective. And the more quantitative it is, the more I think it will be successful when we get into comparison of treatment groups to placebo. And ideally, it would correlate to other features of disease, meaning that we have enough data to suggest that, for example, motor development is correlated to expressive language so that in a clinical trial, we can measure only one of those and understand how it impacts the others. And then ideally, if we could get these in natural environments, this would be great, especially considering how COVID-19 has changed clinical trials, but also considering how many clinical trials we have going forward, particularly for Angelman syndrome. The less travel, the more participation, and the more participation we can get across different socioeconomic groups. And so I want to come back to this clinical relevance because this is something that's near and dear to my heart and very important. We are always thinking about how is what we're doing from a research perspective, not just supporting research in clinical trials and therapeutics, but also how can we utilize this in the clinic more immediately. And so this is an individual who was in a crouch gait even at his age of 4, and you can see it's hard to see with the shadows, but you can see that he's bending and his legs are a little bit closer to the ground. And what we found is if we intervene and pick this up early, we see that he is in less of a crouch pattern. And this is really just special shoes so far that we've done to intervene here, but he's much more balanced and he's not in that crouch gait. And so what we've learned about clinical trials, it's not just the destination, it's the journey. And so what you really have to understand is what are the most common features that cause the most distress in the patient population. It really helps to have an expert team to focus on the granularity of the features and what's really causing them. And one of the things that we've been tasked with actually from a pre-IND meeting at the FDA is to really establish management guidelines. And we saw this with our clinical trial that I described, that individuals entered the clinical trial at different baselines. And so making sure that there's an even playing field for individuals entering clinical trials can really be helpful in seeing that change that we're looking for. You really need objective outcome measures, but you have to be careful because, for example, ERP was objective and statistically significant. But at this point, we still remain confused about what that means. So you need to also make sure that you have correlative measures, which sometimes may be subjective, but that you're correlating it to something quantitative. And what I've learned is actually to put natural history after objective outcome measures. And what we've seen in one of the things we've learned from an Angelman syndrome is that when you put together these natural history studies, you have to understand what I've listed here is 6 through 9 to really do a good job figuring out what you're going to capture and what you're going to do for that natural history study so that you have that database of data over time that really is relevant to what you're thinking about for clinical trials. And so I think this is why we've, even in Angelman syndrome, where we have an FDA-funded natural history study, we've seen lots of companies go back and want to do their own natural history studies. And as much as that can be avoided, I think it helps to not slow the process down. And so I have lots of acknowledgments. In particular, I want to thank my awesome clinical team. I definitely could not do this by myself. I have such a thoughtful and amazing team that is always compassionate and thinking about how we can utilize the information quickly. And then my wonderful collaborators, in particular at UC Davis, who have worked together with me to develop some of these translational outcome measures. So with that, I'll go ahead and take questions.
That was a wonderful presentation. So there is one question right now. I don't know if you can see it, but I could read it to you. It's difficult.
Okay.
It's from Bettina Burek. It's difficult to relate oscillatory frequencies, delta or others, to behavioral measures if they are not taken concurrently with the brain measure. Can EEG be recorded during discrete trials?
So I just want to make sure I understand the question. Are you saying while you're having an EEG done to look at the cognitive measure, so to let, for example, to have the EEG on and do the Bailey at the same time? Um,
That's how I interpret it. So for example,
okay.
as you know, we work with the animals and we do things that can parallel. So while an animal is actively engaged in the behavior, to be recording in vivo in the moving animal.
Yeah, that's an excellent question. And it's something that we definitely have tried to do with the gait measures. So making sure we're measuring the surface EMG while they're doing tasks. To look at firing of the muscles. I think it would be hard to do some of the cognitive measures that we do for Angelman syndrome while an EEG is on, only because it's very distracting. But with the ERP, what we've been doing is looking at tasks while they have the ERP on, which is just a cap. And so it's a great question. I think it's possible. I think we need to be creative about how we make it happen. But there is some data coming out looking at correlation of the Bailey developmental scales from the raw scale as opposed to the scored, and looking at correlation to quantitative EEG. And it looks like there is a correlation of delta power to changes on the Bailey scale. And that has been presented at several of our Angelman meetings, and I'm thinking will probably be out in the literature soon.
So we still have another 10 minutes. I have some questions for you, if that's okay. Because I know we talk a lot about, in terms of natural history studies and interactions with patient advocacy groups. So when we think about design of clinical intervention and clinical trials, integrating real world evidence, kind of the example that you and I had discussed in the past that, in a video game, let's say, where you line up, it's lining up your army for battle, that everything can be perfect and well designed at the very beginning, but as as the army moves in and is into battle, they go into a melee and everything's all over the place. So this notion of integrating real world evidence is starting to gain a lot of traction. Do you have thoughts about this, or how one could potentially integrate what you have done and from your experience with real RWE, just real world evidence in general?
Yeah, that's a great question. What we're trying to do now is to create standards of practice with capture in the natural environment, meaning having clear guidelines of exactly how we want to capture information in the natural environment and how we can work with families to collect that, but then have that as a standard practice so that everybody is collecting the data that we're asking for in a uniform way. And when we go back to score the videos that we're collecting in the natural environment, we have a standard way of doing that as well. And it's only done by a select group of people. So for Duchenne, this has been really successful, and they've showed that there's very nice inter-rater reliability when you create these standards of practice to try to, even though it's done in the natural environment, and you're letting your child be natural, it's controlled in some ways to make the data more uniform and analyzable.
Hmm. And then with respect to natural here, I thought that was very interesting that you put the development or having in hand, having captured the clear, authentic, and objective outcome measures ahead of the natural history study itself. So, what are your thoughts when we discuss this in the broader context, and you hear many groups that want to proceed very rapidly with natural history studies, especially for rare genetic disorders? Um, do you have any thoughts or any comment about if the outcome measure is not developed? It's kind of putting the cart before the horse, and I guess in terms of your timeline.
Yeah, this is a great question too, because one of the things that we missed with Angelman syndrome is this change in gait over time. And so when going back to the RDCRN study and looking to see if there was anything that would capture that nicely, there really wasn't anything, no historic data to suggest that or to change what we were recommending clinically. And so I think doing things in a systematic way is really important. One of those is to do the disease concept model, and there's many innovative ways to do that. One of those can be social listening, so through social media pages. And I will say a good example from Prader-Willi syndrome, where we're also behind in this area, is that we recognize that in Prader-Willi syndrome, sleep disorders and neurologic sleep disorders like narcolepsy are a huge part of that and may actually contribute to some of the more bothersome features that people recognize, like temper outbursts and um, cognition even. And so now we're trying to set up research to collect that data, and that whole data set that was collected already, again, in the same rare disease consortium as Angelman, we missed that feature. So what you want to avoid is very intervenable things that we are not capturing in our natural history, where they could be important aspects to capture that are able to change, especially in older kids with that disorder. So I think being systematic, start with your concept disease model and working with clinicians who have seen a lot of individuals with that particular disorder is very important.
And since we have many trainees online, maybe you could define, so what is a disease concept model?
So a disease concept model can be done in multiple different ways, but essentially it's surveying a lot of individuals, both caretakers, clinicians, and even other stakeholders to collect as much information as possible about what are some of the features of the disorder and how burdensome are they. And so at the end of a disease concept study, you end up with a list of them in an order of the most concerning symptoms for that particular disorder that then charges forward to allow you to really focus on those symptoms.
That's really interesting. And as I mentioned that we have a lot of trainees, and I'm sure they would be very interested in hearing a little bit about your experience as a young investigator and I would say rising star in this field. Can you share a few gems of knowledge from your experience coming from this aspect of here is a disorder that I'm very interested in and now running clinical trials for it.
Well, thank you for saying that. I would say stick with what you're passionate about. I couldn't be more passionate about seeing and being a part of the lives of the kids I see with Angelman syndrome, and don't take no for an answer. I guess is the other one.
No, you mean no with respect to work, you're saying, or
Yeah, I mean, if there's a will, there's always a way. So don't get discouraged along the way if you don't get
that's right.
funding or, you know, sometimes people don't always share your same ideas, but you can always learn from every conversation. But it doesn't mean if one person doesn't believe, it doesn't mean that your ideas aren't good.
Yeah, yeah. And you brought up one point related to in the design of clinical trials now and trying to better integrate different groups that have been historically underrepresented, maybe socioeconomically disadvantaged. And this is a very, I would say, timely and really important aspect of clinical trial design, and just, I would say, the study of rare genetic disorders. Do you have any thoughts about this or how people are going about trying to better integrate aspects of diversity, for example?
Well, I don't think right now we're doing a good job of it. I think the way that we reach out to families, that the providers who are most in the know, who are running the trials, are the ones that enroll their patients, which often are people who travel. And so I think we definitely have a long way to go in terms of helping with this. One of the goals of the emergency line is that if we can get individuals in touch with the network through that emergency line and doing provider to provider consultation, we could educate many providers in the community who are just busy and may not be as aware of all of the research and clinical trials going on. And perhaps we could facilitate that provider getting that individual to clinics or at least implementing some of the standards of care that we have learned that work well for Angelman syndrome.
Yeah, I think that's a great idea. I mean, within the community, as there was an FDA online seminar too, right, about this, and basically people going to the communities and working within the communities for increasing access and making things equitable. I think that's so important. So we have 3 more minutes. We have no other questions here. So thank you again. Before we sign off, I will go over just for the audience the remainder of the day. So after this, we have lunch until let's see, 12:40, and we will have our last 3 symposia, and they're very exciting. And then after that, 10-minute break, we have a really, really exciting graduate student presentation symposia. And if you look at the schedule, that's chaired by Sarah Nelson Potter from the Mind Institute. And then a number of presentations, including Patrick Dwyer from UC Davis, Holly Petz from University of Louisville, Claire Klein from the Center for Autism and Developing Brain, Weill Cornell Medicine, Emery Laurent, University of Wisconsin-Madison, and Megan Krantz, Loma Linda University. And then we will have the updates from NICHD. So Dr. Melissa Prezi is the IDD branch chief, and Sujata Bardhan, who is the health scientist administrator from NICHD. They will provide updates at 3 p.m., that's Central Time. And then finally, 4 o'clock, we will have our closing remarks. So thank you, everyone, for attending. And if we have no other questions, enjoy the rest of your day. And thank you again, Jessica.
Thank you.